This presentation deals with the establishment and strengthening of National Clubfoot treatment programs, with special attention to low-resource environments. This information is based on nearly 10 years of experience by members of the Ponseti International Association, working in more than 50 countries worldwide. We will begin with brief background comments about the Ponseti method and the Ponseti International Association. We will then describe a multi-level model that includes the elements considered essential to establishing and strengthening a successful, sustainable national clubfoot treatment program. This will be followed by a consideration of program leaders or champions and of lessons that have been learned from experiences in a variety of countries. The Ponseti method was developed at the University of Iowa by the late Dr. Ignacio Ponseti, and is now accepted as a global gold standard for treating clubfoot. The method consists of a series of gentle manipulations to stretch the affected tissues and to gradually, but very specifically, realign the bones of the foot. This is followed by a precisely applied plaster cast to hold the new position. Casts are removed weekly, and the manipulations and stretching are repeated, and another cast is applied, each holding the foot in a progressively better position. In most cases, a very small incision is made to release the Achilles tendon before the final plaster cast is applied. In a few weeks, the lengthened tendon grows back together, allowing the final achievement of normal foot and ankle motion. Usually, after 4 to 6 casts, over 4 to 6 weeks, the deformed foot takes on a normal appearance and function. However, corrected feet often have a tendency to return to the deformed posture, called a relapse. When treated as infants, children with clubfoot need to wear a brace up to age 4 while sleeping to maintain the corrected alignment of their feet. The Ponseti method is non-surgical, low cost, requires minimal resources, and is more than 95% effective when administered by a well-trained treatment provider. Long-term results are far superior to surgery or any other treatment method. The Ponseti International Association was established in 2006 and is now an organization of hundreds of healthcare professionals and advocates in countries around the world. The vision of the association is that every child in every country will receive effective treatment for clubfoot using the Ponseti method. PIA, as it is known, engages in a wide range of activities to achieve this vision. These include media and public awareness campaigns such as promotion of World Clubfoot Day, interactions with professional and medical societies in countries around the world, development and distribution of best practice guidelines for treatment providers, maintenance of an international clubfoot registry of cases from dozens of countries, provision of a global web conferencing system to support communication and continuing education, convening of international symposia to advance science and research into clubfoot, participation in more than 100 training activities and programs, and provision of advice and assistance in establishing national clubfoot treatment programs. To achieve the goal of assuring Ponseti method treatment for every child in every country, some 200,000 new cases each year, it is imperative that each country have a comprehensive national program. Although each country and region contains its own unique circumstances and challenges, experience in many countries has led to an understanding of the common essential elements of successful programs, especially those in low-resource environments. These essential elements have been incorporated into the following multi-level conceptual model. The primary focus of any clubfoot program is what is termed the Clubfoot Care pathway. This pathway includes the classic elements of identification, referral, treatment, and follow-up. Identification and referral is usually outside the sphere of influence of the typical healthcare provider and is mostly the responsibility of other public health or community health workers. Treatment, in this case correction of clubfoot deformity using the Ponseti method, is primarily concerned with activities within the clinic. It is clearly the primary responsibility of the trained healthcare provider. Follow-up, in the case of clubfoot, entails adherence to the multi-year bracing protocol and routine monitoring to identify relapses and bracing problems. This portion of the clubfoot care pathway is the primary responsibility of parents, family, or other caregivers. Community support is also important for this phase of care. Several program elements are essential for direct support of in-clinic application of the Ponseti method. We refer to these elements as clinical resources. They include providers and staff involved in direct patient care, physicians, medical officers, physiotherapists, orthotists, cast technicians, nurses, and medical administrative assistants. Parents or other responsible caregivers as partners in the care of their children, and facilities and supplies to support operation of the clinic. First and foremost, each clinic must have a well-trained, skilled treatment provider who adheres strictly to the Ponseti treatment protocol for manipulation and casting. There must be a skilled and knowledgeable clinical assistant to help with cast application. All clinical staff members need to establish open communication channels with parents and family members to actively engage them in the treatment process. Topics that often need to be discussed include the length and cost of treatment, the expected long-term results, the role of parents as treatment partners, potential cast problems, the importance of the bracing protocol, cultural and family issues that may interfere with completing treatment, transportation and lodging issues, and peer support from other parents. Parents and caregivers need to understand and be committed to their role as treatment partners. They need to strictly comply with the treatment bracing protocol, overcome any cultural issues that may be limiting participation in treatment, seek support from their peers, family, and community, manage issues related to transportation, food, lodging, finances, and care of siblings, and provide peer support for other parents as needed. In regard to facilities and supplies, it is important to have a designated clinical space for treating clubfoot patients. In addition to allowing more efficient operations, a designated space provides for interactions among families and patients and provides a better setting for communication and education by staff members. Some locations require that the tenotomy procedure be performed in an operating room. However, when performed in a clinical setting, sterile procedures and materials must be employed. In general, obtaining plaster casting material is not a problem, although the cost can be an issue for some parents and families. High-quality, affordable bracing is, by far, the most common problem in many low-resource environments, although the situation is improving in many areas. With all of the required treatment supplies, quality, availability, and cost are important issues. Reliable supply chains need to be established and maintained. In addition, educational materials need to be available in the clinical setting, and a consistent medical record system needs to be in place. There are program elements that are not directly engaged in clinical services, but are essential for supporting those activities. We have labeled these elements local resources. High-quality, comprehensive training programs are needed not only for direct care providers, but also for others who might play a role in identifying, referring, treating, or following up children with clubfoot. These individuals include obstetricians, pediatricians, primary care physicians, physiotherapists, midwives, nurses, community health workers, traditional birth attendants, immunization workers, and others. Local health administrators are needed to support training of providers and staff, to provide required facilities such as dedicated clinic space, and to assure the procurement of materials and supplies. Families, community health workers, and others, such as community organizations, service clubs, and local non-governmental organizations, are needed to provide awareness that clubfoot is treatable, to help identify children with clubfoot, and to assist in overcoming social, cultural, and financial constraints to completing treatment. There is consensus among experienced providers around the world that achieving competency in applying the Ponseti method requires more than the traditional continuing education approach for healthcare practitioners. Although the application of plaster cast seems like a routine procedure, the serial casting associated with effective clubfoot correction requires considerable mentoring and practice to master. Introductory courses reach broad audiences, but only serve to identify those practitioners who are interested in becoming trained providers. Interested candidates must participate in a fellowship program in which they are closely mentored by an experienced provider and participate in the treatment of at least 25 patients. After a newly trained provider establishes his or her own clubfoot clinic, an experienced mentor, visiting professor, should visit to help the new practitioner refine clinical skills, organize the clinic, and provide advice on treating unusual or problem cases. Web conferencing, internet communications, and participation in symposia and continuing education programs should be used to help practitioners maintain their skill level. Frontline health workers and community organizations, along with families, play important roles in patient identification and referral, as well as in follow-up during the casting and bracing periods. These individuals should be provided with appropriate educational programs and materials, including training videos, posters, handouts, and similar items. Support from the local hospital or clinic administration is essential. Administrators are always presented with competing priorities for limited resources, so it is important that administrators understand that treating clubfoot with the Ponseti method is low cost, low resource, and high impact. It is not unexpected that some health administrators might be reluctant to support establishing Ponseti-based clubfoot services because of financial pressure from practitioners to continue surgical treatment of clubfoot. Conversely, the fact that non-surgical treatment of clubfoot will save money and resources is a strong argument for adopting the Ponseti method. In order to achieve long-term stability and be comprehensive in its reach, a national clubfoot program needs organizations and entities that are broad-based and can help support the delivery of clubfoot treatment at multiple clinic sites in multiple locations. We have labeled these elements national resources. These include health professional societies, training institutions and health professional schools, state or regional health systems, depending upon the situation in each country, the national health system, and the public media. Endorsement from health professional societies for adopting the Ponseti method has proven to be highly important on both the local and national levels. Having such an endorsement makes it easier to convince local administrators and reluctant colleagues to recognize and support Ponseti treatment. Additionally, professional societies can be very instrumental in setting standards of care and adopting best practice guidelines, thus influencing the country's training institutions. Long-term sustainability of a national clubfoot treatment program depends on institutionalizing the training of future practitioners regarding clubfoot and its treatment. Lectures should be presented to all medical students and allied health students so that they are aware that clubfoot can be readily and completely corrected. Resource materials, including best practice guidelines, should be readily available for those who are interested in pursuing this topic further. Orthopedic residents and others to whom clubfoot children are likely to be referred should receive comprehensive training and mentoring in applying the Ponseti method as part of their clinical training programs. Depending on the organization of the health system, support for clubfoot treatment at the state or regional level may be critical. A formal memorandum of understanding with the responsible health administrators can provide program continuity when individual administrators change positions. Support in one state or region can often have a positive influence on neighboring states or regions within a country. Similar to the situation at the local level, administrators at the state or regional level must decide where to devote limited resources. The same argument can be made. The Ponseti method is low cost, low resource, high impact, and therefore highly cost effective. The situation at the national level is very similar to that at the local and state or regional levels. A memorandum of understanding and formal adoption of best practice guidelines are the foundation for a sustainable program. In addition to the humanitarian aspects of providing a normal and productive life for its young citizens, it can be helpful to point out at the national level that there are significant long-term economic benefits to reducing the number of disabled individuals in society and reducing the cost associated with low productivity and increased social services for those who will unnecessarily go through life with a serious disability if left untreated. Widespread awareness that clubfoot is treatable is one of the foundational elements of a successful national treatment program. Additionally, those seeking treatment need to know where to find the closest treatment center. There are a number of factors that must be considered, including language. What are the local terms for clubfoot? What is the literacy of the local population? Are pictures and models better than written communication channels? Information sources. What is the credibility of the various communication channels available to local communities? Who are the trusted authority figures? And what are the local beliefs about clubfoot and its causes? What is the level of stigma associated with having a child with clubfoot in the family or community? These factors need to be well understood in order to reach every child needing treatment. A national clubfoot treatment program should have 4 core values as its foundation. These include high quality of care through rigorous adherence to the Ponseti method, equity for all patients. Treatment should be available to every child who needs it. Local ownership of the program. Local health professionals should be in charge. And sustainability, as evidenced by 3 characteristics. The treatment program is integrated into the available healthcare services. The program functions effectively for the foreseeable future. And the program uses resources mobilized by the community and the government. A national program needs to be developed and expanded by individuals that are referred to as program champions. These are usually individuals who have learned about the Ponseti method through the medical literature, a conference or program, or from a colleague. They become convinced that this treatment method should become the standard of care in their region or country. They are usually respected leaders, and they are in key positions to influence others. With appropriate guidance, they engage others to form a core group of change agents who facilitate program development and advocate for the Ponseti method. Although there may be one highly motivated individual working hard to initiate a national program, no program is successful without a team of champions. And it is imperative that the team collectively have a diverse set of skills and interests to help build the various essential elements of the program as described earlier. Team members need to set aside issues of status, seniority, and personality to work together for the common cause. Once the core champions have been identified, a key first step is to develop a detailed strategic plan. The team may enlist someone with professional expertise in planning, or they may utilize one of many well-established planning tools, such as a SWOT analysis. SWOT refers to the process of identifying the internal strengths and weaknesses of the team of champions, as well as identifying the opportunities and threats related to program development from external organizations and even individuals. Regardless of the planning tools, the result of the process must be a detailed plan, including a timeline, budget, and responsibilities. There is no strict order for developing the various essential elements of a national clubfoot program. The process must be adapted to circumstances in each country. However, experience in developing a number of programs has provided some food for thought in this regard. One or more skilled treatment providers is a common starting point for a program. A training mentoring program to expand a core group of champions is often a next step. As the clinical success of the treatment becomes evident, local health administrators can be engaged to help with facilities and supplies needed to expand services, at least in initial selected sites. As treatment capacity increases, typically parents become strong advocates for the services, and they seek out support from the community and other healthcare workers. Success at one or more locations can be used to convince regional and eventually national health system administrators of the benefits of a nationwide program. A staged, well-planned media campaign should be undertaken once sufficient treatment capacity is in place. Long-term sustainability of the program is dependent on utilizing the Ponseti method as a standard of care within both professional societies and training institutions. There are several key points about building a national program that are important to remember. Mentoring and monitoring are essential. One-on-one mentoring is required to learn the Ponseti method correctly, and a short course is only an introduction. Documentation of successful outcomes is the best way to grow the program. The results of treatment will speak for themselves. Recognition of the Ponseti method by medical societies can be very influential with health administrators in supporting the program, and can hasten adoption of appropriate curriculum materials by training institutions. Keep in mind that the eventual goal is to have a national program owned by everyone, serving every child. It is important to not generate demand for clubfoot services before there is treatment capacity to meet that demand. Providing inadequate, poor quality services will set back development of the national program, and it will be difficult to regain the trust of nearly everyone involved. The goal of assuring Ponseti method treatment for every child in every country is dependent upon establishing national programs that are high quality, equitable, locally directed, and sustainable. The goal is achievable one country at a time. More information about building national clubfoot programs can be found at www.ponseti.info or by contacting the Ponseti International Association at the address, phone number, or email shown here.